It's Sam's first day after orientation, and he is really excited. He's been dreaming about being a part of healthcare delivery for a long time, and he's worked really hard to get there. He spends the morning trying to remember people's names and researching the rare diagnosis that one of his patients has. There isn't much out there. He also spends one solid hour trying to decipher the hospital's transfusion protocols, which look nothing like he's read about. His stomach starts to grumble, and as he thinks about taking a break to find some food, his phone rings. It's the head of research, asking if now's a good time to approach one of his patients for enrollment in a study on patient education materials. Sam thinks it would be better to wait since the patient is finally resting comfortably after some radiology studies. But he's not sure how the director will take it. After all, she said, we need to get our numbers up before recruitment ends next week. It's fine to say come back later. Or is it? Whew. What a morning. Sam's first day sounds much like my first day. Uncertainty, like the kind Sam and so many of us have experienced, has been acknowledged as a challenge in healthcare for decades. The literature is ripe with examples of how uncertainty manifests in a variety of healthcare settings and has real consequences for decision-making, quality of care, training outcomes, as well as staff and patient engagement. Identifying different types of uncertainty helps us acknowledge its presence and subsequently develop solutions to manage that uncertainty. One model of uncertainty in complex healthcare systems suggests that uncertainty spans three overlapping domains: personal, practical, and scientific. Personal, practical, and scientific. Personal uncertainty includes psychosocial, existential, and ethical components. Will I survive this? Am I doing the right thing? Was that interaction I had a healthy one? Sam's grumbling stomach and his reaction to the research director fall squarely into this domain. Practical uncertainty relates to how we get stuff done, uncertainty about the structures and processes of care, and how those various structures and processes fit into what Henry just described as a complex adaptive system. The blood bank protocol is just one manifestation of the practical uncertainties that Sam faced this morning. Scientific uncertainty includes diagnostic, prognostic, and treatment uncertainties. That rare diagnosis that one of Sam's patients has brings uncertainty on how best to counsel and treat the patient, truly challenging for both patient and healthcare team who have the shared goal of trying to get the patient back home safely. The COVID-19 pandemic is a true exemplar of these overlapping domains of uncertainty. As Professor Tricia Greenhall and colleagues put it in a recent blog that they published on uncertainty in COVID-19, they said the COVID-19 pandemic is a complex problem in a complex system. As the pandemic continues to mature, uncertainties continue to multiply. Is it safe to reopen schools? How best to address the long-term health sequelae of this virus? What multifaceted solutions must we put in place to address the injustices that have so clearly been brought into focus during this time? I am privileged to be a healthcare quality leader in the Bronx, New York, and the large trauma center that I serve is one of 11 acute care facilities within New York City Health and Hospitals, the largest municipal healthcare system in the United States. Like all of you, we've faced and continue to face tremendous uncertainty as we deliver care. I'd like to share with you 3 examples of how we drew from contemporary quality improvement techniques, including simulation and the human side of change, to address uncertainty during the peak of COVID-19 surge in New York City, beginning in March of 2020. The first example I'd like to share with you relates to the implementation of a safety spotter program. In the special pathogens literature, trained observers have often been used to mitigate safety threats and help staff properly use their personal protective equipment. We rapidly deployed a safety spotter program as cases of COVID-19 began to increase because we recognized that the personal and practical uncertainty related to PPE use, as well as evolving PPE guidelines, meant that we needed to address the uncertainty where the work was being done. We used simulation to train 32 observers in PPE use, as well as just-in-time coaching techniques. These simulations were very low tech, using the PPE that those observers would actually later on use in the clinical environment. The simulations were performed in the hallways right outside the units or within the units themselves. These spotters were assigned to 10 COVID units, and their function was to assist teams with PPE, perform just-in-time coaching, and maintain situational awareness to mitigate contamination risks. As guidance changed, we retrained the spotters, who in turn helped retrain staff. In July of 2020, the NHS Nightingale Temporary COVID-19 Hospital published its experience implementing a role they called the Bedside Learning Coordinator. The function of this coordinator was to make observations for improvement and collate suggestions daily. Similarly, we collected feedback from spotters on the units about PPE challenges and other opportunities for safety and flow optimization. One optimization was a series of PPE tips based on common challenges that were identified. What you see here was a tip that was developed after the spotters saw staff in multiple areas touching their masks during removal. This tip prompts staff to remove their masks from the straps, an area that is less likely to be contaminated. This tips resource was shared with the rest of the system, and the nature of tips evolved over time as staff became more comfortable with PPE, decreasing the practical uncertainty around PPE. Based on the resounding staff feedback, as well as how much safer they felt with the spotters in place, as well as our rates of staff infection and antibody seroconversion, we believe that this safety spotter program decreased personal and practical uncertainty for our staff and helped keep them safe. While we hope we don't have to redeploy such a program, through simulation, we have the machinery and expertise to do so if necessary. The second example I'd like to share with you is a holistic strategy to decrease uncertainty to promote staff well-being. The well-being of our staff has been a key priority long before pandemic. Our system's quality improvement leadership had to quickly adapt operations to mobilize additional resources to address staff well-being during the surge. School closures meant that thousands of staff lacked reliable childcare. The system arranged complimentary daycare or in-home childcare services for more than 1,500 children of healthcare staff. Temporary lodging was made available through negotiated agreements at nearby hotels, free of charge. More than 2,300 staff utilized this program in March and April of 2020 alone, mitigating the real practical uncertainty of how to physically distance from people you live with, especially in an urban environment like the one that we are in. With philanthropic support, we were able to provide free, delicious meals for staff during their shifts, as well as groceries to send home. Where to put signage and how to safely distribute meals was simulated right before the arrival of a very huge food truck, which included a full kitchen. Here you can see two of the many armed service members who joined us during peak surge, ready to hand out grab-and-go meals to our staff. It was amazing to watch hundreds of meals coming in, hundreds of meals going out, and so on. Addressing uncertainty around these basic needs, such as childcare, shelter, and food, was crucial to staff well-being. We directly address the emotional needs of staff by harnessing our existing peer support second victim program, known as Helping Healers Heal. 90 peer support champions and behavioral health providers in the Bronx-based hospital that I serve, all of whom who had received simulation-based debriefing training, visited every clinical and non-clinical area of the hospital. I'm proud to say that we have been able to check in on every staff member regardless of tour or profession, handing out snacks, asking how they're doing, escalating to social workers or therapists as needed. I'm also really proud of the fact that areas that sometimes get forgotten during duress, such as parking valet and food service, were also able to receive this peer check-in. Many staff have expressed trepidation about the unknowns ahead, and our peer support team will be one way we embrace and address those uncertainties. The third example I'd like to talk about relates to enhancing communication. Communicating updates in a way that is timely and reach the people they need to reach is really challenging at baseline, and the heightened personal, practical, and scientific uncertainty of COVID-19 really took that challenge to a whole new level. We used a multi-pronged approach to try to get the word out. A repository of up-to-date resources was added to the main page of our intranet site, and this was sometimes updated several times a day. Daily emails from our hospital leadership provided crucial information to staff, including updates on how many patients had been successfully discharged. Using the flat screens that typically contain patient education and other announcements to display clinical guidance. Here's one of our amazing members of our healthcare team. She was stationed at one of our entrances. And as you can see on the flat screen over her shoulder, there's a PPE tip that's displayed on that flat screen. As we push past the initial surge of pandemic in New York City, we must contemplate what quality and safety initiatives make sense to address while also maintaining vigilance for a potential second wave of COVID-19 cases. This post-surge pre-vaccine phase necessitates a new way of thinking, where we honor the tremendous psychosocial impact of the pandemic and harness the lessons learned from our experience. One approach to mitigate a parallel pandemic of emotional harm is to ensure that quality and safety initiatives explicitly promote psychological safety and empathy, two foundational elements of addressing uncertainty. This prioritization matrix that we developed tightly links psychological safety and empathy with the more traditional quality improvement goal of maximal clinical and operational benefit. Using this matrix can help identify must-do quality and safety initiatives that both strongly promote psychological safety and empathy and have substantial clinical and operational benefit. Despite all our efforts with all sorts of communication formats, one project that falls squarely into the must-do category is to enhance bidirectional communication. We have actively sought out feedback on what worked and what to change for the future from staff in all different areas. We will simulate potential solutions to trial their impact and loop back with staff regarding their opinions on what innovations worked and what to hardwire for the future, pandemic or not. Uncertainty has been and will continue to be a feature of healthcare delivery long after this pandemic has subsided. I urge each of you to consider 3 ways to address uncertainty. Number 1, embrace it. It's going to be with us. Naming it, acknowledging it, and the way it makes us feel and act is crucial to managing it. I have to say, this is not easy to do. I sometimes don't like it because it's very hard to swallow that my team and I don't have a handle of situation. But it's the right thing to do to move us forward. Number 2, consider strategies that purposely address the 3 overlapping domains of uncertainty: personal, practical, and scientific. Take stock of whether your existing quality improvement efforts have an opportunity to enhance messaging and actions around these various elements of uncertainty. Simulation is a dynamic quality improvement technique and can be utilized to mitigate uncertainty quickly and effectively. Number 3, we live in a super connected world. 20 minutes in a room of colleagues, 20 minutes in a room of physically distant colleagues, or on Twitter, and you can crowdsource all sorts of new ideas to address a problem. Build opportunities for discussion, collaboration, and feedback. People are our most important healthcare resource. Harness their wisdom to co-create an approach to address uncertainty. There will not always be a solution to solve the uncertainty, but that crowdsourced wisdom will tell you how to embrace and message that uncertainty. Though there will continue to be uncertainty all around us, there are a few things I am quite certain about. One, my twins, Annika and Arjun, are super cute. Two, I would like to continue to wear yoga pants to work on occasion. And number three, I am 100% certain that our collective experience over the last several months has allowed us the real opportunity not just to reimagine healthcare delivery, but also to reimagine how it feels to deliver that care. I am energized by knowing with certainty that you, me, we will do that together. Thank you.